Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 482 of our pharmacotherapy series, which majors in hematopoietic cell transplantation. TAW, a 60 kilograms, 165 centimeter, 15-year-old boy, is day positive 79 after a matched, unrelated, non-myeloablative peripheral blood progenitor cell transplant for acute lymphocytic leukemia in third complete remission. He presents to the clinic for evaluation of a temperature of 102.3 degrees Fahrenheit and a 3-day history of non-productive cough. Significant medical history includes skin and gastrointestinal graft versus host disease. Stable on his current regimen of cyclosporine, mycophenolate mofetil, and prednisone, and congestive heart failure believed to be secondary to anthracite exposure. TAW has chronic low-grade nausea and hypomagnesemia necessitating daily IV hydration with magnesium supplementation. His relevant laboratory values are as follows. Sodium of 138 milliequivalents per liter. Potassium of 4.2 milliequivalents per liter. Chloride of 100 milliequivalents per liter. Bicarbonate of 23 milliequivalents per liter. Blood urea nitrogen of 18 mg per deciliter. Serum creatinine of 0.8 mg per deciliter. A total bilirubin of 0.6 mg per deciliter. Magnesium of 1.5 mg per deciliter. A WBC count of 3,500 cells per microliter. Platelets, 78,000 per microliter. An absolute neutrophil count of 1,810 cells per microliter. A hemoglobin of 10.8 grams per deciliter. He was CMV seropositive and HSV seropositive before hematopoietic cell transplantation. Oral medications include cyclosporine 275 mg every 12 hours, mycophenolate mofetil 900 mg every 12 hours, prednisone 60 mg every morning and 12.5 mg every evening, tapering, trimethoprim sulfamethoxazole, TMP, SMX, 160 mg/800 mg twice daily on Monday and Tuesday, fluconazole 400 mg every morning, valacyclovir 500 mg twice daily, digoxin 0.125 mg every 12 hours, enalapril 10 mg every 12 hours, and a multivitamin every morning. On physical examination, TAW is a chronically ill-appearing child with moon face, dry skin with thickened areas, a pleural friction rub, and thinning hair. Blood cultures, urinalysis, and chest X-ray are obtained. Chest X-ray reveals several small cavitary lesions worrisome for fungal disease. TAW is admitted for further workup and management of presumed Aspergillus infection. So my question to you is, What risk factors does TAW have for developing an infection with Aspergillus? Invasive molds, most commonly Aspergillus species, but also Fusarium species, Pseudosporium, and zygomycetes, are an increasing cause of morbidity and mortality after allogeneic and autologous hematopoietic cell transplantation. Factors contributing to this trend include a. More effective prevention of bacterial and viral infection which promote mold overgrowth, as described previously, and b. The use of fluconazole prophylaxis, which has reduced the incidence of candidemia and candida-related mortality. Aspergillus infection is reported in up to 26% of hematopoietic cell transplantation recipients, and the mortality rate of invasive aspergillosis is 74% to 92%. Several risk factors for development of invasive fungal infection have been identified. Given that neutrophils are critical for host defense, prolonged neutropenia is considered the single most important predictor of infection at any point after hematopoietic cell transplantation. Graft versus host disease, that is acute and chronic, and treatment with corticosteroids are also important risk factors, particularly for aspergillosis, presumably as a result of neutrophil dysfunction. In addition, the widespread use of fluconazole prophylaxis, 400 mg per day for prevention of invasive candidiasis in transplant patients since the early 1990s has led to a substantial increase in the incidence of invasive aspergillosis and also fluconazole-resistant Candida species such as Candida krusei and Candida glabrata. TAW is receiving corticosteroid treatment for graft versus host disease and fluconazole prophylaxis. These therapies increase his risk for exhibiting invasive aspergillosis. TAW undergoes bronchoalveolar lavage to identify the organism responsible for his pulmonary infection. Pathologic examination of the fluid obtained reveals septate, branching hyphae, and culture results confirm the diagnosis of Aspergillus fumigatus infection. Imaging scans are negative for extrapulmonary involvement. So my question to you reads: how is aspergillosis usually diagnosed, and what are the acceptable alternatives for treating this infection? Early diagnosis and treatment of invasive aspergillosis, which rely on tissue or fluid obtained from the infected site followed by aggressive antifungal therapy, may improve patient survival. Although the lower respiratory tract is frequently the primary focus of infection, Aspergillus may invade blood vessels and spread hematogenously to other organs, including the brain, liver, kidneys, spleen, and skin. Head, chest, abdomen, and pelvic computed tomography scans assist in assessing the extent of disease, treatment options, and overall prognosis. Cultures of respiratory tract secretions lack sensitivity for detecting Aspergillus, and the medical condition of the patient may preclude invasive diagnostic procedures altogether. Many clinicians have adopted the European Organization for Research and Treatment of Cancer criteria for diagnosis of proven, probable, and possible invasive aspergillosis. Newer diagnostic tests based on the detection of fungal antigens or metabolites, such as galactomannan, 1,3-beta-D-glucan, and fungal DNA detection by PCR, are being developed. Galactomannan is a polysaccharide component of the Aspergillus cell wall that is released during fungal cell growth. Galactomannan detection by enzyme-linked immunoassay, abbreviated as GMAA, has proved to be a sensitive and specific tool for early detection of Aspergillus infection. The test is useful not only for serum samples, but also for bronchoalveolar lavage and cerebrospinal fluid. Concomitant antifungal therapy may cause false negative results, whereas antibiotics of fungal origin, e.g., piperacillin, tazobactam, have been associated with false positives. We will now briefly look at antifungals. Outcomes for patients with invasive aspergillosis after hematopoietic cell transplantation are often poor, with approximately 20% of patients alive after 1 year. Treatment success depends not only on the use of intensive antifungal agents, but also on recovery of the host immune system and/or reduction of immunosuppression. Conventional amphotericin B had traditionally been the gold standard antifungal therapy for invasive aspergillosis, with response rates in the range of 28% to 51%, depending on the severity of the underlying immunosuppression. However, 65% of responders eventually died of their infection. Fortunately, broad-spectrum triazoles and echinocandins are available as alternatives. The treatment of invasive aspergillosis has moved away from the use of amphotericin to the use of broad-spectrum azoles for its treatment. 3 broad-spectrum triazole agents, itraconazole, voriconazole, and posaconazole, are available for patients. In an early compassionate use trial of invasive aspergillosis unresponsive to amphotericin B, 27% of patients had a complete response to itraconazole, and another 35% experienced improvement in their infection. Patients who had undergone hematopoietic cell transplantation had response rates similar to patients who were less immunocompromised. Unfortunately, oral itraconazole capsules exhibit erratic absorption, and the IV form is complicated by the risk of drug precipitation in the IV line. In addition, itraconazole is a potent inhibitor of common CYP isoforms and also has negative inotropic properties. Voriconazole is one of the newer broad-spectrum azoles whose advantage is its excellent 96% oral bioavailability. Voriconazole has been compared to conventional amphotericin B in a randomized, unblinded trial as primary therapy for established invasive aspergillosis in an immunocompromised host. The primary objective was to demonstrate the non-inferiority of voriconazole compared with conventional amphotericin B after 12 weeks of therapy in patients with definite or probable invasive aspergillosis. Patients received voriconazole 6 mg per kilogram IV every 12 hours for 2 doses, followed by 4 mg per kilogram IV every 12 hours for at least 7 days, followed by oral voriconazole 200 mg every 12 hours or amphotericin B at a dose of 1 to 1.5 mg per kilogram per day. Patients refractory to or intolerant of initial therapy could receive other antifungal drugs. Of 144 evaluable patients who received voriconazole, 7.6, that is 52.8%, had a partial or complete response compared to 42 of 133, that is 31.6%, patients treated with amphotericin B. The median duration of therapy for patients treated with voriconazole was 77 days, and 52 of 144 patients switched to an alternative agent. In contrast, the median duration of therapy for patients receiving amphotericin B was 10 days, and 107 of 133 patients switched to another agent, most commonly, a lipid formulation of amphotericin B. The survival rate at 12 weeks in the voriconazole group was 70.8% compared to 57.9%, with a p-value equal to 0.02. These results of initial therapy with voriconazole indicate superior response and improved survival in immunocompromised patients, such as allogeneic hematopoietic cell transplantation recipients, with invasive aspergillosis. Voriconazole-treated patients also experienced fewer drug-related adverse effects. However, drug interactions due to P453A4 inhibition should be closely monitored. Posaconazole, a newer broad-spectrum triazole, is available as an oral suspension, oral tablets and an intravenous formulation. The oral suspension has a more variable absorption as compared to the tablet formulation. In general, posaconazole has the lowest minimum inhibitory concentration of any available triazole against Aspergillus species, including Aspergillus terreus. It is the only triazole with activity against the zygomycetes. Published clinical experience with posaconazole is limited. However, in an open-label externally controlled trial in patients with invasive aspergillosis refractory to or intolerant of other therapies, the overall success rate was 42% in posaconazole-treated patients compared to 26% for controls, with a p-value of 0.006. Echinocandin antifungal agents, caspofungin, anadulafungin or micafungin, inhibit the synthesis of beta-1,3-glucan, an important component of the fungal cell wall. No prospective randomized trials have documented the efficacy of any echinocandin for primary therapy of invasive aspergillosis, and only caspofungin is approved for salvage therapy. An open-label, non-comparative trial evaluated the efficacy of caspofungin in 69 patients who had failed or were intolerant of at least 7 days of standard antifungal therapy. Patients received 70 mg IV of caspofungin on day 1 followed by 50 mg IV daily. Of the 63 evaluable patients, 26, that is 43%, responded favorably to treatment. 26 of 52 patients, that is 50%, who had received at least 7 days of therapy had a favorable response. In another open-label, non-comparative trial, Denning et al. Evaluated the safety and efficacy of micafungin, alone or in combination, in patients with proven or probable aspergillosis. 80 of 225 patients, that is 35.6%, had a favorable response. Most patients received combination therapy. The 34 patients treated with monotherapy had a similar response rate. Amphotericin B is no longer first-line therapy for the treatment of invasive aspergillosis. It is typically reserved for patients who develop mold infections, such as Cryptococcus, that are resistant to the azoles. In summary, the number of agents available to manage invasive aspergillosis has expanded greatly in the past decade. Although some experts believe that voriconazole is the drug of first choice, considerable controversy still exists regarding acquiring resistance, selecting out other species of molds, and side effect tolerance due to the lack of definitive studies. Therapy should be tailored to the individual patient based on response, tolerability, and cost. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 483.